Good evening, all. Myself, Pravallika, Associate Professor, Department of Obstetrics and Gynecological Nursing, Faculty of Prakara. Today, I am here to have a small discussion regarding history of midwifery in India, as well as little we shall discuss regarding trends in midwifery care and how we will be evaluating the maternity services in India, like which includes as vital indicators. Because through vital indicators only, we can able to evaluate how the services are provided to the mothers as well as for the newborns. So first we shall see about history of midwifery in India. So why this history is essential to us? Without history, there is no present. Without present, there is no future. So how midwifery has started, who all has contributed. So we shall be learning through this historical aspects already. Like this word, the midwife, derived from an English word that is midwife, which means with the women. So already from the word itself, we can able to understand that the midwife is a person who cares for the women during the pregnancy, labor, and even after the labor also. That means antenatal, intranatal, and postnatal services also. So midwife is a person who has knowledge and skills to assist with the women in the childbearing process. Like as I already mentioned, the childbearing process includes the antenatal, intranatal, and the postnatal period. So on a whole, midwife is a person or midwife is a woman who cares for the women antenatally, intranatally, as well as during the postnatal periods. Coming to the definition, which is given by International Confederation of Midwives in 2015, a midwife is a person who is having been regularly admitted to a midwifery educational program, which is duly recognized in the country in which it is located, has successfully completed the prescribed course of studies in midwifery, has acquired the requisite qualifications to be registered and or legally licensed to practice midwifery. So on a whole, this definition is nothing but midwife is a person who should have an educational qualification according to the particular country that they are living. So in India means as prescribed by our INC, they should have that educational qualification. So not only educationally being qualified, that means not only having a degree or not only having a diploma certificate, they should also be licensed to practice. That means they should be registered under that nursing councils also. Then only it is indicating that they are licensed to practice. They should have an educational qualification. At the same time, they should be registered to practice where they are living. So then only that person will be considered as a midwife according to International Confederation of Midwives. And next we shall see about history of midwifery. So this history of midwifery, as I already mentioned, was contributed by many individuals. So which was started or initiated by Hippocrates in the 460 BC itself. So he was considered as the father of scientific medicine. And he said that, he used to say that like fetus has to fight in its own way to come out of the womb as well as its membranes. So fetus has to fight if it has to come out during the process of delivery. So in this way, he has contributed to the midwifery and all. And coming to the second person, that is Aristotle, in the year of 384 to 322 BC, he was considered as the father of embryology, and he is the one who described the uterus as well as female pelvic organs. Like what is the structure of uterus? What is the parts of uterus? How does the pelvic organs are present? What all includes in the pelvic organs? Like where does the uterus is present? Where does the fallopian tubes are associated, attached to this? Where does the ovaries are present? All this particular description regarding the female reproductive, that means uterus and the pelvic organs, was given by this Aristotle only. And coming to the next person, that is Soranus. He was the one who was specialized in the obstetrics and gynecology. And he has even written books for the midwives in the year, which was used for around 1500 years, it seems. And he is the one who has used vaginal speculum and even advice regarding the cord care and wet nursing also. Like if you observe, each individual has their own contribution towards the midwifery and obstetrics. Like one has written book, like one has written or one has given description regarding the uterus and pelvic organs, and one has described that the uterus has to do fight and come its own way to come out of the uterus. And he is the one who has even given description for the vaginal speculum and even regarding the cord care also. Because cord care is very essential for the newborn. Like if this cord care is not done properly in the essential newborn care, which may leads to lot many infections for the baby, like newborn, and even which may increase even neonatal mortality rate also. In the same way, to examine the internal organs, this vaginal speculum is very, very essential. So all these two inventions are done by the Soranus itself. So he is the one who has written book first for the midwives. And coming to the next individual, that is Leonardo da Vinci. So he was in the years of 1452 to 1519, and he is the one who has made anatomical drawings of pregnant uterus. So if we observe, the previous person has only given description regarding how the uterus will be and where does the placement in the pelvic organs, what all the organs are attached to that uterus. Only that kind of description was given by the previous individuals. So he had made little more advancement, and he is the one who has drawn like what is the position of the baby, in which presentation does the baby lies, what is the lie of the child. So all that anatomical drawings were drawn by this Leonardo da Vinci. In the year of 1513, so he is the one who has written a book for the midwifery, which was printed in the Germany. So he has written a book which was printed in the Germany, like on to the contributions of Soranus itself. So first book was written by Soranus, but in the Germany, first book was printed by this Leonardo da Vinci based on the contributions of the Soranus itself. And coming to the next individual, that is Vesalius, in the year of 1543. He is the one who has opened the full-term pregnant uterus in lower animal and extract the fetus out. And even he is the one who has demonstrated the uterus as a single chamber organ. So till that, nobody knows that the uterus is a single chamber organ and how does the baby lies in it also. But he is the one, as he is the one who has done or who has opened the full-term uterus, but not in the human beings, in the animals. But he has described or he has invented or he has mentioned that uterus is a single chamber organ. And how does the fetus fit into the uterus also he has mentioned. So he's none other than Vesalius in the year of 1543. And coming to the next individual, that is Ambroise Paré, from the years of 1510 to 1590, and he laid a foundation for the modern obstetrics. So he is the one who has given some stone for the modern obstetrics and all. And he is the one who has performed even the internal podalic version and successfully delivered a woman. So you know, might be already regarding this version. Version is the thing that we will be molding the presentation and lie of the fetus. For example, this podalic version. So usually we will bring the favorable pole to the lower pole of the uterus. Like for example, if the baby is in the podalic presentation, we will bring the head to down. So usually these versions we are having in two forms, like cephalic version as well as podalic version also. So he is the one who has performed the internal podalic version. So usually this internal podalic version will be done once the rupture of the membrane take place only. So where one hand will be upon to the abdomen, one hand will be introduced into the vagina. So where they hold one of the leg of the fetus and they pull down for the delivery to take place. But there is a higher chances even for the rupture of membranes if it is not done properly. But this Ambroise pair has successfully implemented this internal podalic version and even skillfully delivered that particular women also. And he is the one who has first delivered the women upon a birthing stools and all. So previously, if we check out, even to this birthing positions also, different birthing positions were used to be used to deliver the women. Like some used to use like standing postures, like some used to use like squatting postures, and he is the one who has delivered the women in birthing stools. And later it has been modified to like birthing beds, birthing tables. So like that, lot of inventions has taken place, but Ambroise Pair is the one who has invented, who has delivered women upon the birthing stool. And also he is the person who has done the perineal lacerations also. Like nowadays, after that, lot many implementations like episiotomy cut used to be given and it was used to get suture, but he has done the lacerations for the perineal, sutures for the perineal lacerations. And he has founded a school for midwives in the Paris as well as the France also. So these were the contributions by the Ambroise Pale in the years of 1510 to 1590. So there are lot many contributions. Main things are internal podalic version, birthing stools, and suturing of perineal lacerations. And he is the one who has invented or who has introduced school for the midwives in Paris and France. And coming to the next individual, that is Louis Borges. So he is the one, or she, Louis Borges is a midwife who is trained by Ambroise Fair. And she used to attend the ladies of French court. So the queens of the French court was used to be attended by this Louis Borges. And she is the one who has warned the other midwives like regarding sexually transmitted infections at that particular period. Like main sexually transmitted infections were syphilis. So we know that syphilis gets transmitted through genital secretions and so if the midwives are infected, so as the care for the other women during the labor process, they may have the possibility to infect the other women. So it was warned by this Louis Borges and all. And she is the one who has recommended induction of delivery or induction of labor for pelvic contraction. This pelvic contraction is nothing but when the pelvis is smaller than comparing to this like average diameters and all, we usually consider in a on a whole like a small pelvis is considered as like pelvic contraction. So in case of pelvic contraction, like induction used to be done in order to avoid the excessive like full weight gain for the fetus, where we cannot able to deliver because of cephalopelvic disproportion or fetal pelvic contractions and all. So she has introduced like pelvic contracted women can undergo for the induction of labor for successfully delivering a child. So these were the contribution which was made by this Louis Burgess. And the next person was like Julius Caesar Aranci. So he is the one who has written the first book for the Italian midwives and which ran about 17 editions and all. So this is also one more like contribution which was made by this Julius Caesar Aranci. And also he has advised that cesarean section can be done for the contracted pelvis. As fetus cannot able to pass through this contracted pelvis, they can able to undergo for the cesarean section for the delivery to take place. So these were the contributions which were made by this Julius Caesar Aranci. And the next person was William Harvey. From the years of 1578 to 1657, he was considered as the father of British midwifery, and he is the one who has written first English textbook for the midwives and all. So till now we have seen like for the Italian midwives, Italian books were there and some books were written in Germany, German language, but not the books which were written in the English. So this William Harvey is the one who has written first book in English for the midwives. And he has even described about the fetal circulation also. Like actually this William Harvey is the person who has even described regarding the adult circulation and even for the fetal circulation also. Like there are some alterations happens in the fetal circulation. Like usually, the lungs are the respiratory organs, whereas in the fetal circulation, the placenta is the respiratory organ. Like how many umbilical veins are present, how many umbilical arteries are present, like regarding this ductus arteriosus, ductus venosus, and all this foramen ovale. All these descriptions of fetal circulation was given by this William Harvey itself. And what is the role of placenta? How does this respiration is done by the placenta? And he was the one who has first delivered the placenta by massaging the uterus. So in the third stage of labor, usually there will be delivery of the placenta take place. But in some women, there needs to have the active measures for the delivery of this placenta. That active measures includes massaging the uterus. So he is the first person who has delivered the placenta by giving massage to the uterus. And coming to the next individual in the history of midwifery is the French King Louis XIV. In the year of 1663, he has employed a Paris surgeon to attend one of his mistress in the labor and pleased with the result. Like before that also, cesarean section were done. Cesarean section were done and the baby's getting delivered. But what is the outcome? So do the mother and child are in the safer condition or not? Like nobody has given any other descriptions at all. But whom he has employed, so they have given a good outcome. The mother and baby are healthy. So he was very much satisfied with the outcome of that particular surgeries that they have conducted for delivering the fetus, for delivering the child out of the mother's womb. And he is the one, this king, French King Louis XIV, is the one who has given or who has honored that particular surgeon with the name of accoucheur. So from then, these surgeons conducting delivery, like who conduct the cesarean section, operational deliveries, they were called as like accoucheurs. And French accoucheurs has built a school for midwifery and which attracted the doctors from all around the Europe also. Like not only he has done the surgeries and all that accoucheurs, all that surgeons who were conducting operational deliveries has come together and has developed a school for the midwifery and which was attracted or which has attracted all other doctors also from the country of Europe. So this is the contribution which was made by this French king Louis XIV in the year of 1663. So on a whole, what is the key term you have to remember here is he has honored the surgeon who has conducted the operational delivery for his ladies in his court as with the name of accoucheur. And next we shall see regarding Mauricio in the year of 1668. So he is the one who has published treatise on midwifery. So he also has written a book or he also has published a book in the midwifery and Hugh Chamberlain has translated it in the English. So he has published in some other language in Britain and the Chamberlain was the one has translated it into English, which has greatly assisted the advanced midwifery in the Britain. So like this, little contributions made by this Mauricio also in the year of 1668. And he is the one not only writing the book in English or in Britain, and he's also described what is the attitude of the fetus in the uterus. Till then, nobody knows that. Nobody has described what is the attitude of fetus. So what is this attitude is nothing but the relation of fetal extremities with the fetal trunk. So here, if we observe how he has described the relation of fetal extremities with the fetal trunk is like one squatting down. Here he has described as the baby is squatting down to pass stools and lowering his head to see what he has done. So nothing but he has said that. So the extremities of the fetus is completely flexed and even the head also is completely flexed. So complete flexion is the attitude. So that he has described in a differential terms and all. So he said that the child is squatting and passed to stool and he is observing what he has done and he is looking into what he has done. So like that he has described how does the attitude of the fetus in the mother's womb. And next is a person that is Chamberlain in the year of 1675. He has designed the obstetric forceps. So in this particular image, you can see the obstetric forceps and all, like in some indications, like where the mother is completely exhausted to push out the baby. And when there is little assistance is required, or when you wanted to cut short the second stage of labor, like in cases of some medical indications or in the fetal indications also, like fetus is having distress or the mother is having some cardiovascular disorders where the mother is not supposed to have a greater cardiac efforts. So in that particular periods, they will be using these as like assistive devices for delivery of the child. So like obstetric forceps, usually we are having different obstetric forceps are there, like outlet forceps are there, cavity forceps are there, and even inlet forceps are there, long curved forceps are there, wriggly forceps are there, different forceps are there. So whatever may be the forceps also, the use of the forceps is to assist the women during the delivery in cases of any of the indications of maternal exhaustion or something. I'm coming to the next individual, that is William Smellie. So, in the years of 1697 to 1763, he was called as the British midwifery because he has made that many contributions. That's what he was called as the father of British midwifery. And he explained that the labor to be a mechanical process and described the pelvimetry, cephalometry, forceps delivery of the after coming head of the breech. So this pelvimetry is nothing but, so as I already mentioned, for the normal delivery to take place or for the normal mechanism of labor to take place, there must be adequate pelvis must be present. And even the head of the child, that means the cephalic prominence, the cephalic head of the child must be adequately sized. The pelvis cannot be small as well as the head also cannot be bigger. So measuring whether the pelvis is of adequate sized or not, either by clinical pelvimetry, that means nothing but they introduce the fingers inside. So how much of curvature is there, like how is the cavity, how much of outlet is there, how much of what is that the angles are present, everything they will be measuring, nothing but in order to ensure that whether the pelvis is adequate or not. And at the same time cephalometry also. So what is the size of the fetal head? Is the fetal head is very big or the fetal head is average size? Can it able to enter or can it able to go through the pelvis and all? So like inlet, cavity, outlet. So can it able to go? Can it able to have its own manners during the delivery process? All that will be identified through this pelvimetry only. So this description also was given by this William Smellie itself. And at the same time, he has given description regarding forceps delivery of the after coming head of the breech. So what is this after coming head of the breech is? In the breech presentation, we know that the buttocks of the child will be at the lower pole of the uterus, where the head will be occupying at the fundus of the uterus. So when the buttocks already has delivered from the uterus, next is the turn for the shoulders. When whole of the body, buttocks, shoulders are delivered, only the head is remaining inside the uterus. So this kind of term we call it, we use here as like after coming head of the breech. So head is remaining still inside the uterus, whereas the rest of body and the buttocks of the child has got delivered. So in this, how to get delivered? There are some assistive methods are there, like Burns-Marshall methods, like different methods are there. So like head flexion, jaw traction, different methods are there. He has described regarding how we have to deliver. And at the same time, even forceps delivery, like there are some specialized forceps are also present. So how to deliver with the use of that forceps for this after coming head of the breech was described by this William Smellie in the years of 1697 to 1763. So these were the major contributions, but not only these are the individuals who has contributed to the history of midwifery. There are even more individuals. The chair of midwifery was founded in the 1726 in the University of Edinburgh. So before that, we have said only regarding the birthing stool. So after that, they have introduced even the birthing chairs also. And in the year of 1772, John Leake has replaced the obstacle stools with a special delivery beds. So as I already mentioned, even in the birthing positions also, different inventions or different innovations has taken place if we have gone through all these sports, all this history. Like first, it was like as I said, standing position, squatting position, and already I mentioned regarding birthing stools, birthing chairs. Now all these has been replaced with the birthing special delivery beds in the year of 1772 by this person who is named as John. And there was an individual who is also called as Charles White. In the year of 1773, he has stated that what is puerperal fever? So during the puerperium of the women, that means within the 6 weeks, so if the woman develops any infection or if the woman develops fever, anything which is associated with the care that it is provided during the delivery process, it is called as puerperial sepsis or puerperial fever. So it is an infectious, and how they can able to reduce the instance of that puerperial fever or sepsis also as mentioned. So he has used lime as a disinfectant to clean the linen, and even he has said that isolation plays an important role in order to treat these individuals of puerperial fever, and adequate ventilation and sitting posture to facilitate the proper drainage. So if the drainage is not there, according to Florence environmental theory also, we know that so a wound has to be healed fastly means there should be adequate light must be there. There should be good ventilation must be there. At the same time, cleanliness must be there. And whatever is draining from there, that the secretions has to get drained off. So then only the wound gets healed faster. So this was described by Charles White. On a whole, what is his invention is puerperial sepsis is one of the reason for increasing the maternal mortality as well as morbidity rates. So how we can able to control is by the usage of lime as a disinfectant and other methods also as mentioned. And coming to the next individual, that is Fielding out. In the year of 1710 to 1789, he has described the mechanism of normal labor, and even he is the one who has performed even the episiotomy also. So he is the one who has performed the mechanism of normal labor and performed even the episiotomy also. So this mechanism of normal labor includes like lot many steps are there, like 10 steps are there, like engagement is there, descent is there, flexion is there, like internal rotation is there, crowning is there, like restitution will be there, extension of the head will be there, like internal rotation of the shoulders, external rotation of the head. Like that, some 10 steps will be there in the mechanism of labor. So that was described by this Fielding owl only. So till then, no one knows that how does the rotations take place for the fetus during the delivery process in the mechanism of labor and all. And at the same time, he has even performed the episiotomy also. So before that, I have said that one individual has done the suturing only for the perineal lacerations because they were not given this episiotomy conduct. So this episiotomy cut is the cut which is given upon to the perineum in order to deliver the fetus in case of visit perineum, in case of primi gravida, in case of when you wanted to give extra access for the fetal head to get delivered, this kind of episiotomy will be done. So he is the one who has even performed the episiotomy and successfully conducted the delivery. And the next individual was Gordon in the year of 1795. He has described that puerperial sepsis as a wound contamination of the placental site. So till then, like there are lot many reasons for the puerperial sepsis, like endogenous sources are there, like exogenous sources, gram positive organisms are there, gram negative and he is the person who has introduced stethoscope, and Francois in the year of 1818 has first recognized fetal heart sounds in the pregnant uterus. So to say that the fetal heart rate, whether it is normal or the fetus is having distress, so only by knowing the fetal heart rate only. So where the fetus heart rate we can be able to find that. And even with the use of stethoscope also, fetal heart rate can be identified. So all these contributions were made by this Lenec and Francois only. So these were the contributions which were made by Lennox and Francois in the succeeding years. Next person is James Young Simpson. In the year of 1847, he has used chloroform first in the obstetrics for anesthesia. Because already we have mentioned that it used like cesarean sections were getting done. And in the animals, it was first done. After that, in the French court, surgeries were done for the delivery of the women. And he's the one who has introduced chloroform as like an anesthesia and all. And the next person was Semmelweis. In the year of 1861, he has demonstrated what could be the cause for the puerperial sepsis and even suggested even for the preventive measures also. So before some other individuals has said like puerperial sepsis is due to the contamination or contamination of placental site they have mentioned. But what is the exact reason why they are developing? What organisms are causing? What exogenous, what endogenous, what autogenous organisms are causing, how they can able to prevent the occurrence. So all this information, all this description was given by this MLVs only. And coming to the next individual, that is Louis Pasteur in the year of 1879. He has written a book or he has written a thesis on puerperial sepsis, and he's demonstrated that the presence of streptococci in the lochia, blood in the fetal cases of peritoneal cavity also. So he said that the reason for the organism even for the puerperial sepsis also. Before the other persons has mentioned what is the reason, how to prevent it. But this Louis Pasteur has even found that in the lochia is nothing but the bloody discharge from the vagina after the delivery. So this streptococci organism also he has identified in the blood and all. And a French obstetrician, that is Francois Mauricio, has even first reported cesarean section. So though many has did cesarean section, he is the one who has first reported cesarean section in the year of 1668. And in 1876, Poro has performed even subtotal hysterectomy also. Like subtotal hysterectomy is like partial hysterectomy. Hysterectomy is nothing but removal of the uterus. Like he is the one who has first performed this subtotal hysterectomy. And Max Sanger in the year of 1882 has even first sutured that uterine walls also. So even you can able to observe that this is the abdominal delivery which is getting done like through cesarean section, lower segmental cesarean section. So these are the contributions which were made by different individuals in the contribution of midwifery practices. Next, we shall be moving to trends of maternity care in the India. Like trends are nothing but the changes that has taken place in the maternity services in the India. Like how the maternity services before and at present and what the expectations even for the users of this maternity care are not being the same. So what changes has made or what changes has taken place in the expectations of maternity care we shall be seeing here. Like changes in the social structure, variations in the family lifestyle. Like the lifestyle and the family structures are not being the same. Like in the previous days, if we go through, like most of the joint families used to be there. Like usually, like home deliveries only used to happen. But nowadays, if you see, like nuclear families, and most of even the women, those who are in the reproductive age group also, like working women only. Like in the previous days, like usually like grandmothers and all, most of the women used to live in the home and home deliveries only. So some lifestyle changes has happened, social structure, even the family structure also has been changed. And the cost containment. So now, even now, the reduction of the cost they do expect. So reduction of cost with high quality care. So what is the expectations of consumers of healthcare practices of maternity care is like with reduction, like less cost with high quality care needs to be provided. And for that, how this cost containment can be done is by efficient services and at the same time, even the reducing of length of stay. So even with increasing of length of stay of the hospitals, also there can be a possibility for increasing the cost of expenditure of that particular services also. Even cost containment is also one of the trend of maternity care in India. And the third thing is like expanded roles of nurses. So nowadays, if you observe, the roles of the nurses has been changed enormously. Before that, the nurses in the maternity services also. And next one is family-centered care. So this family-centered care is nothing but usually nowadays that the families are expecting the involvement of family in the care and all. Like nowadays, if you observe in the labor rooms also, like even the husband also is allowed. The other in-laws and all even not allowed also. They are expecting that their involvement also in the provision of care, and access to healthcare has been increased. Like nowadays, like hospitals has been increased in the rural areas also, the hospitals has been set up. One or the other way, there is an access for the healthcare for all the women. That's what has decreased even the mortality rates of the individuals also. And shortening of hospital stay, as I already mentioned. If you check out now in the uncomplicated cases, mostly within 2 days after the normal labor, the women are getting discharged. That kind of trend also has been changed. And increased use of alternative treatment modalities. Like now, if you check out, the trend has been completely changed. Before that, like allopathy used to be more, like drugs, medications used to be more. But nowadays, this trend of alternative treatment modalities has been increased, like usage of yoga, therapeutic touch, like massage, all these, like all these kind of alternative and complementary therapies has been used in the maternity care services also. And increased use of technology. If we see like in vitro fertilizations in the fertility care, or else Doppler therapies or Doppler ultrasonography, all these are like increased technologies only. Technology has been advanced in the provision of care services, and increased cost of high-tech care. So they are expecting high-tech care, like everything of advanced care they are expecting. Obviously, even the cost also is getting increased. And changing patterns of childbirth. So nowadays they want to be like all the delivery process to be like homely kind of atmosphere. And nowadays, if you see like home setup based, like the women, some of the women are getting delivered in their home itself through water birth process, where the midwife goes to their own home and they conduct deliveries, and all these kind of changes also has happened. And increased perinatal risk factors also. The increased perinatal risk factors can be from the mother's side as well as for the newborn side also, like low birth weight can be a reason, or else maternal anemia can be a reason, or whatever is the reason also, there are increased risk factors for the women as well as the child also. Raising cesarean birth rates, comparing to the previous days, nowadays the cesarean section rates have been increased. Whatever may be the reason, that may be because of sophisticated lifestyle, or that may be because the women doesn't want to go with the labor pains. So most of the women are opting for the cesarean birth, and the rate of cesarean section has been increased, and increased number of intensive care units. So in order to save the child life, especially NICU setups has been increased. As I already said, there is a role of father in the provision of maternity services for the women, and psychological support during the labor, as these family members are allowed to provide psychological support for the women during the delivery process. And painless delivery. So this painless delivery, where the women will not feel for the this kind of labor pains during the delivery process until the actual labor starts. So epidural analgesia will be given continuously, and where the women like will not be feeling for the pain. So this is also one more trend. And robotic delivery, where robots are conducting the delivery for the women. So all these are the changes that has taken place for the maternity care in the India. And next we shall see about how does the midwifery has changed in the India. Like some transformation has taken place in the education and the setup of the midwifery also, that we shall be seeing here. Transformative education for relationship-based transformative midwifery practice. The education has changed, and even the practice of midwifery also has got changed. So why this transformation has taken place in the education as well as the midwifery practice in the India is in order to strengthen the midwifery education and practice only. So why this midwifery education and practice has to be strengthened? So the midwives are meant for caring the women or to reduce the maternal and neonatal mortality and morbidity rates only. If the midwifery education has been strengthened, or if the practice has been strengthened, so obviously there will be improvement in the maternal and neonatal outcomes itself. So the main concept or the main goal of this transformation of midwifery education or the practice in India is in order to improve certain sorts of maternal and neonatal health in the India itself. So this transformative midwifery education in the India is focusing on these key elements such as competency-based training. So what are the capabilities of that particular nurse? So these competencies has to be increased. So what competencies in the midwife has to be increased? Because as I already mentioned, midwife is a person who attends the women during the antenatal period, intranatal period, as well as during the postnatal period also. So she should have an in-depth knowledge regarding the physiological changes that are happening or that will happen during the antenatal period, or how does the first stage of labor take place, what kind of changes happens, or how she has to manage during the first stage of labor, how she has to care the women, or how she has to care for the intranatal cases, how she has to care during the second stage, which includes during the episiotomy time, how the episiotomy has to be given, how the care has to be provided, what kind of support has to be given during the delivery process, soon after the birth of the baby, what kind of care needs to be provided, so how warmth has to be given. So all these competencies need to be trained to the midwives. That is nothing but competency based training. So on a whole, after this transformation education, the midwife must be highly knowledgeable and highly skillful so that a good maternity and neonatal services has to be provided. And person-centered and relationship-based care. So this person-centered and relationship-based care includes like continuity of care must be there. So everybody has to be treated equally and complete care has to be provided. And at the same time, when they are caring for the women during this pregnancy or during this midwifery services, they have to provide a holistic care approach. So what is this holistic care? The nurse is not meant for only for treating the physical changes or physiological illness of the individual. So she is the one who has to treat or who has to provide care in all the whole aspect. Like holistic is nothing but whole aspect, which include physical, emotional, social, mental, and even spiritual aspects also. Not only for the women, even for the newborn, as well as for the siblings, family members, everybody she has to care for. So that kind of what changes, what physiological changes, what mental changes happens, what spiritual changes happens, what kind of emotional changes happens within the family as well as the women, the nurse must be or the midwife must be aware of. So these all concept has to be included in the education. So on a whole, the key elements of this transformative midwifery education includes is competency-based training, person-centered as well as holistic care approach. And next we shall see about transformating role of midwife in the healthcare and all. So what changes has happened in the educational programs of midwife we have seen. So what changes has happened in the practice of midwifery we will be seeing. So in order to bring a transformating role for the midwife in the healthcare of India, in the year of 2018, Indian government has launched a midwifery services initiative under National Health Mission. So under this National Health Mission, some services related to midwifery has been launched by this Indian government in the year of 2018. So according to that, what all that services it includes is midwife-led care units. So midwife-led care units will be present in all the hospitals. So what is the purpose of this midwifery-led care units or midwife-led care units includes is, this will include the midwives who can able to provide the high standard of care or high quality of care to the maternal as well as for the neonate also. So what is the main importance of this midwife-led care units are including is there will be having a high skillful midwives will be there who can able to monitor and at the same time provide services to the mother as well as for the neonates and all. And at the same time, some training programs even started by the Indian government, which includes nurse practitioner in midwifery program. So we might be seeing like advanced nurse practitioners as like general nursing services in the nursing care. In the same way, we are having like advanced nurse practitioner courses also. So this even in every government colleges, in some of the government colleges, even it is getting implemented like nurse midwifery practitioner courses. So where they are having like specialized knowledge, specialized skills will be taught to that particular midwives and all. So it is introduced to provide high trained midwives and all. So nurses has to be highly capable in the provision of maternity services. So this is the main scope or the main target of this transforming of role of midwives in the healthcare of India, as well as for the transforming of education of midwives in the India. So only whether the role of the midwife, the practice has been altered or the education has been altered. So only the target is the high quality midwives has to be provided to the community. So who can able to reduce the maternal mortality as well as neonatal mortality. So as I was mentioning throughout this session, the how can we able to evaluate one's own services are by seeing these vital indicators only. So the next we are going to discuss is regarding the vital indicators. How does the maternity services are provided in the India? Whether in an up to mark, whether the services are provided or whether any lacunae is present. Through these vital health indicators only we can able to check out. That vital health indicators are including maternal mortality rate, infant mortality rate, neonatal mortality rate, fertility rates, as well as maternal death audit. So what is that? One after the other we will be seeing. So the first one includes is maternal mortality rate. So the maternal mortality rate includes the death of women. The mortality means itself is the death. So the death of the women either while pregnant or within 42 days of termination of pregnancy, irrespective of whatever may be the duration and site of the pregnancy, from any cause which is related to or aggravated by the pregnancy and its management, but not from accidental or incidental causes. So that kind of deaths related to are called as maternal mortality rate. They were included under the maternal mortality rate. So nothing but if the woman is dying during the pregnancy or during the delivery or within 42 days after the delivery or after the termination, whether it may be an abortion or whether it may be whatever may be the site of pregnancy. It may be of intrauterine pregnancy, intraperitoneal pregnancy, or it may be like some other tubal pregnancy also. All this can be considered as like maternal mortality rate only. So what is the reason for this maternal mortality? What is the reason for the mothers or the women to die either during the pregnancy, during the labor, or during the puerperium within the 42 days? Is there are lot many causes are there, like obstetric causes are there, non-obstetric causes are there, as well as social factors are there. Like obstetric causes include toxemias of pregnancy, like hypertension disorders, like preeclampsia, eclampsia. Because of this, the women can be dying, or hemorrhages, like antepartum hemorrhages, or what is that, postpartum hemorrhages, or sepsis, infections during the pregnancy, or during the labor, or during the puerperium, also can lead to this maternal mortality rate. And the non-obstetric causes includes like medical surgical conditions like anemia, any other medical surgical disorder like cardiac disorders complicating pregnancy, or else the woman is having any other medical disorders, or else any surgical disorders like heart disorders, like congenital heart disorders. All this can also leads to maternal mortality and all. And social factors which includes age at childbirth, like the teenage pregnancies will be there, like before the 19 years of age itself, they will be conceived. So their body is not well prepared for this physiological changes to happen during the pregnancy or during the labor. So even that also. And parity, like too much of grand multiparity we say, like 5 deliveries conducted, 6 deliveries conducted. So there is no much birth space between. So even then the women may have complete anemia and may leads to death rate. And too close pregnancies, as I already said, the interval between the pregnancies is maybe like the women will be there like within 1 year also they will be coming for the delivery, like family size, malnutrition, poverty, illiteracy, lack of maternity services. That means there is no access for the maternity care services. All this can lead to maternal mortality rate. And next, the indicator of the maternity services is infant mortality rate. So infant is below 1 year of age group. The baby within 1 year of age group is called as infant mortality rate. So how many babies are living or how many babies are dying within 1 year of age group is called as infant mortality rate. So there is a formula for this, like number of deaths of children less than 1 year of age in a year divided by number of live births in the same year. How many babies are born? From them, how many babies are dead within 1 year of age multiplied by 1000. is considered as infant mortality rate. So if we see what could be the causes, as already we have mentioned, for the maternal mortality rate, lot many causes are there. In the same way, for the infant mortality rate also, there are lot many causes are there, which includes is low birth weight. The birth weight of the baby is very less, or else postnatal asphyxia. The baby is not able to take breathe properly, or else some birth injuries during forceps delivery or venous delivery, or else because of any other instruments, or else during the standing posture the delivery has happened, cephalohematoma, caput succeedina. There could be some birth injuries will be there. And congenital malformation like congenital heart disease, like what is that? Atrial septal defect, ventricular septal defect, tetralogy of palate. All these can lead to infant mortality rate. And acute respiratory infections also. If the lungs are not well matured enough. So even there is a chance or a possibility for this infant mortality rate. So this is a second indicator of the services that are provided from the health team and all. And coming to the third indicator, that is neonatal mortality rate. So neonate is the one or the term we use till 28 days of age. So number of deaths of children under 28 days of age in a year is considered as neonatal mortality rate. So there is a formula for this, like number of deaths of children under 28 days of age in a year divided by number of live births in the same year, which is multiplied by 1000. So the reasons are like same. So whether it is before 1 year or before 28 days, the causes are same, like low birth weight, postnatal asphyxia, birth injuries, congenital malformation, and even hemolytic diseases of newborn, like RH incompatibilities, hydrops vitalis also can be other reasons for this neonatal mortality rate. And next, we shall see the next indicator, that is perinatal mortality rate. The formula for this perinatal mortality rate is early neonatal deaths, that is first 1 week in a year, and divided by live births in the same year. So which is related to this perinatal, like either during the pregnancy or during the delivery process or during the after the delivery. If the deaths are happening, they are considered as like perinatal mortality rate, which is multiplied by 1000 is considered as like perinatal mortality rate. And the causes includes like there are antenatal causes, intranatal causes, and postnatal causes also. Like antenatal causes includes maternal diseases. Already I mentioned, like toxemias, cardiac disorders complicating pregnancy, or any surgical illnesses complicating pregnancy, or else myocardial infarction, sudden, or amniotic fluid embolism. So all this can lead to, and pelvic diseases also, anatomical defects like the uterus is having some anatomical defects, endocrine imbalances, where we can see about in diabetes mellitus, thyroid disorders, in all the conditions. At the same time, in some intranatal causes also we can able to see, like birth injuries for the newborn, asphyxia, prolonged delivery time, or else obstetrical complications, as I already mentioned, like antepartum hemorrhage, or else twin gestation, breech deliveries, what else? All these also can be considered as like intranatal complications. And postnatal complications include prematurity, baby is not matured well, and respiratory distress syndrome, congenital anomalies. All this can lead to perinatal mortality rate. And coming to the next indicator, that is fertility rates. So fertility rates is nothing but the fertile rate. So here there are some rates are there, we shall see. Like the first one is birth rate. So this birth rate is calculated as the number of live births during the year divided by mid-year population, which is multiplied by 1000. So if you are using this particular formula, we can able to check out what is the birth rate of that particular year, and at the same time general fertility rate. So the number of live births in an year during the year in an area during the year, which is divided by mid-year population, which is aged between 15 to 45 in the same year, same area, and in the same year, which is multiplied by 1000. Like it is nothing but in the reproductive age women, how many are giving live birth, which is multiplied by 1000, is considered as like general fertility rate. And coming to the next one, that is of total fertility rate. So it includes like total average number of children a woman would be able to have if she's in the reproductive age and in the same rate, which is as like a general fertility rate. So how many babies she's able to give birth if she's in the reproductive span itself. So that is considered as like total fertility rate. So this way we can able to identify the fertility rates and all. So there are some more fertility rates, which includes age-specific fertility rate. So these are the number of live births in a year to a woman in any age, in any specified age group. So here they do the comparison, like with one age, like 2 or 3 people they'll be taking. How many the first individual has had the children? How many second individual had? How many third individual had? So like that, to their particular age group, how many people or how many children they can able to give birth is considered as like age specific fertility rate. And the next one is like gross reproductive rate. So it is the average number of girls that would be born to be a married woman if she experiences the current fertility pattern throughout her reproductive span. So how many average the women can able to give birth during her reproductive span is called as gross reproductive rate. And coming to the last one, that is of net reproductive rate. So the number of daughters a newborn girl will bear during her lifetime, assuming a fixed age-specific fertility as well as mortality rate. So soon after the birth of the baby, like a newborn, a girl child is there. So how many a girl child can able to bear during her fixed age period is called as net reproductive rate. So gross reproductive rate is throughout her reproductive span, how many children. And net specific rate, net reproductive rate is in particular age group, how many children she will be able to bear. So that is called as net reproductive rate. And coming to the last indicator of this vital indicators, vital health indicators is maternal death audit. So usually this maternal death audit happens in the all healthcare sectors. Like if one death happens of maternal death happens means what is the reason for that maternal death? So is provision of healthcare services is not adequate is a reason, or is any other reasons are there? Does the mother or does that woman had any other medical disorders or any obstacle complications have made, or else a poor access to healthcare has made her to have this maternal death? What is the reason? Evaluating is nothing but this maternal death audit. So a maternal death audit is nothing but it is an in-depth systematic review of maternal deaths to delineate their underlying health, social, and other contributory factors to prevent similar future deaths and all. So now one death has happened of maternal death means we should able to prevent that no maternal deaths happening in the future. So we can able to ensure that no maternal deaths happens in the future is only based on what could be the reason for this present death. So what made her to develop, what contributing factors. So all that if you are able to know, then we can able to prevent the occurrence in the future also. So all this, that in-depth systematic review included in this maternal death audit itself. So till now we have discussed regarding history of midwifery in the India and transformations of midwifery educational services, education as well as practice in India, and what kind of changes has taken place in the maternity services, and at the same time how we can able to evaluate the vital health indicators like maternal mortality rate, neonatal mortality rate, infant mortality rate, maternal death audit. All these things we have discussed. To explore more about this particular content, you can download Prakara app and go through. Thank you.